Welcome to today's webinar, the review of the SAMHSA Strategic Initiative, Public Awareness and Support for SBIRT. We have three trainers today, Jim Aiello, Holly Hagel, and Tracy McPherson. And Holly will be starting the presentation, so I will give her the screen. Hey, Holly, it's all yours.
Okay, give me 1 second and I will get it started. Well, thanks everyone. I see we have people logging in and I'm getting ready to show my screen, so we should be ready to go here in 1 second. I see you're seeing my very first slide. I want to thank, as Chris already mentioned, there's three of us that are going to be leading this discussion today about SAMHSA Strategic Initiative, the specific initiative number 8. I think we need, Chris, you might need to mute yourself. I hear you typing.
Oh, sorry.
It's okay. I'll just assume everybody can hear me fine, and if not, somebody will open a chat or question and let me know, or just unmute yourself and let me know. So we're going to lead this discussion to talk about SBIRT in multiple settings and locations. So in case you forgot what we look like about 3 seconds ago, I have a slide showing who each of us are. And so we hope to take you through the next 3-hour webinar session, which will include a brief break about midway through. I just want to say at the outset that I have a bit of a summer cold, so if there's like a slight delay in my speech, it might be that I'm getting a sip of my tea or something. As Christine already mentioned, we really encourage interaction. I myself will pause after I speak on each of the sections I'm going to speak on and just see if you guys have any thoughts. It doesn't necessarily have to be a question. It can be a reflection or a thought about what we just discussed, and or you could share an idea that you might have, or you can ask a question. And you can do that by using the questions or chat functions in your panel, or you can raise your hand icon as Christine showed you, and we will unmute your audio and try to take that. Okay, but before we get started, I'm going to go ahead and ask Chris to launch the polls. We would like to get to know you guys a little bit better and see where you're from, what audiences you all represent today, and that will also help us sort of tailor our questions. So Chris, do you want to launch the first one, or would you rather I do that?
I'm doing it right now. Okay. The first poll question is, what is your current professional role? Are you a counselor, therapist, social worker, or a case manager? A nurse, nurse practitioner, physician, or physician assistant? Program or unit administrator? University student or faculty? Or other?
I see we have 56% voted. Let's leave it open.
Yeah, and if you are in the other category and want us to know what that is, please just put that in the chat or questions box, so we will be able to have that recorded in the webinar.
Okay, we're at 73% have voted out of, right now we have 38 people on the webinar, so go ahead, Chris, why don't you share that?
Sure. Okay, I'm going to close this now and we'll share the results. Okay, here are the results of this poll. 52% are counselors or therapists, social workers, case managers. 4% are in the healthcare profession as nurses or physicians. 20% program or unit administrators. 4% student faculty at universities, and 20% are other. So there is more than half are in the social work counselor group.
I see we got some also in the question panel. Somebody indicated they were from a poison control center and a student. And I see if you can, Chris, there's a question that after you launch this poll, maybe you can help them. They have a technical question about.
Sure. Okay. Okay, so we're going to go on to the next poll now, just a moment. Okay, just a second here. Okay, this one is, what field do you represent? mental health, addictions, physical health, education, or EAP.
I see we have a little bit more of a range here, and we have 71% voted. Again, we have about 40 people on this webinar right now.
Okay, it looks like we have a pretty good good range of answers, so I'll close this one and then we'll share the response. Okay, 19% mental health, 48% addiction, 15% physical health, 15% education, and 4% EAP.
Great.
That's a nice group.
Okay, we can go on to the next one.
Yes. Okay, this one's a real simple yes or no. Do you conduct SBIRT interventions now?
It seems like a simple question, but it's always interesting for us to know. That way maybe you could share some of your insights if you do have been utilizing SBIRT to those who are new to SBIRT. And if you're new to SBIRT, we like to know that so that maybe we can answer specific questions for people who are considering using it.
Okay, well, as we can see from the people who answered this, that 3/4 of the people do not currently conduct SBIRT interventions, so we have 24% that do.
Okay.
And we have one more question for you. Okay, this is another yes or no. Do you see your agency using SBIRT? If you don't already use it where you work, do you think that, are they interested in starting to use SBIRT? Or would you like them to use SBIRT? Okay, I think we have a pretty good indication here of the responses. So, 87%, that's the highest I've seen in any of our webinars. So 87% of people say that they do see their agency using SBIRT, whether they do it now or in the near future. 13% say no. So that's a good indication of the interest in this topic. So Holly, I'm going to hide this now, and you will have your feedback.
Okay, and I thank you very much for doing the polls. Thank you guys for participating on the questions and chat panel, too. That's very important. It helps us also engage with you guys because it's awfully quiet when I'm just staring at my laptop here in the webinar. Also, I'd like to tell Tracy and Jim, if you guys want to interrupt while I'm talking and further illustrate a point I might be making, feel free to unmute yourself and go ahead and do that. That won't bother me in the slightest. I'll pick up right where I left off from. Okay. So, again, if you have any questions or thoughts while I'm speaking, please go ahead and use the questions and chat panel. I will stop and ask if anybody wants to make a point after I go through each of the each of the areas of my part of the presentation. Okay, so I'm going to start by talking about why we even wanted to talk about increasing public awareness and support. Let me go back to the title of this presentation. Kind of, Chris, you can hear you typing.
Oh, shoot, I'm so sorry.
It's okay. I just think her phone is right at the level of the speakers, too, so it's pretty loud. All right, we're good now. So we're reviewing SAMHSA's Strategic 8 Initiative, number 8, which is the 8th initiative out of 8, called Public Awareness and Support, and how that applies to SBIRT. And so many of you indicated that you're already utilizing SBIRT. Maybe we'll inspire you to utilize SBIRT in other sectors of your work. And for those of you who are interested in using it, hopefully we'll push you over into implementation and actually start. So what SAMHSA has made, and not just SAMHSA, but a lot of addictions researchers, NIDA and IEEE, that over the years we have, as a society, increased our awareness and connection between certain physical issues and prevention and treatment and early detection, such as hypertension or stroke or heart disease. And that we should apply that same concept to the idea of mental health and substance use disorders and take action earlier on in the course, maybe when people are using at various levels of risk, low, moderate, or high, before longer-term consequences of the diagnosis of substance use disorders. So the whole idea behind this is to increase public awareness, public education. So that is one of the connections between this initiative and SBIRT. Just to review, the objectives of this webinar is to increase our understanding of how SBIRT can be an integral part of general services in multiple sectors of society and in a variety of settings. Certainly, we are not even limited to the settings that we're going to discuss today. There's a few that we left out, like the criminal justice settings. SBIRT could be applied there. And so SBIRT is like a feel-good and evidence-based intervention. We like to talk about it because it does fit a public health model and will serve this goal of increasing public support. So we're going to examine multiple ways to implement SBIRT in a variety of settings, and then we're going to talk about how some tools and resources that will be available for SBIRT implementation. Okay, specifically we're going to apply SBIRT to multiple sectors of society in a variety of settings like the workplace, hospitals, which of course health and hospital settings has been the most probably researched area, and beginnings of SBIRT have come out of trying to implement SBIRT in ERs and hospitals, and we're going to examine those in depth. So SAMHSA, or the Substance Abuse and Mental Health Services Administration within the U.S. Department of Health and Human Services, is the lead in the public health efforts to advance behavioral health of our country. And I think that, you know, speaks highly of what the 8 initiatives are trying to achieve. So I felt like it was important to go back to SAMHSA's core mission, which is to reduce the impact of substance abuse and mental illness on American communities, or America's communities. That's the core of SAMHSA's mission, and SBIRT fits right into that. In 2011, SAMHSA published their Leading Change, a plan for SAMHSA's role and actions. And I encourage you all, if you haven't already looked at it, you'll get the slides at the end of the webinar, to click on this link, or you could just put in that into Google or Bing search engine and come up to the PDF file and review the document. Again, we're only going over strategic initiative number 8. There's 7 more to go over, and you might find some ideas and action steps that you could take. And let's see here. So here are the 8 initiatives: the prevention of substance abuse and mental illness, trauma and justice, military families, recovery support, health reform, health information technology, data outcomes and quality, and public awareness and support. And I highlighted that because that is the strategy we're going to focus on today. When we wrote this ATTC grant, we had to address how SBIRT kind of fit into all 8 of these categories, and it actually does fit very nicely into all 8 categories, and we'll probably do a future webinar on that very topic. All right, let me just check in with you guys. It just seems so quiet on my end, but I assume if I don't see any hand raised or questions, icons, that everybody's following along with me and you can hear me okay. Okay, so the purpose, SAMHSA has published the Leading Change document, and they've also published nicely companion pieces for each of the Strategic 8 initiatives. So I took the purpose from their website for the public awareness and support, which is to increase understanding of mental and substance use disorders and many pathways to recovery to achieve the full potential of prevention and help people recognize mental and substance use disorders, to recognize them early, I'll add that piece, and seek assistance with some urgency as any other health condition. So This puts, substance use disorders and mental health disorders on par with physical health because we are a whole person, and that is really a focus of increasing our attention around looking for these issues earlier on in the course of use. So how is SBIRT related? Well, we think that SBIRT is an integral part of general services, and it can occur in not just healthcare, but the workplace and education, and indeed behavioral health settings. And many people who aren't in the addictions field, although many of you indicated that you were, may be surprised to know that a lot of community mental health centers do not really address addiction issues. Maybe they address co-occurring issues, but they don't address low or moderate risky use of substances. Excuse me. So this is a way to get at both. All right. So I thought I can't assume that everybody on this webinar knows anything about SBIRT, so I wanted to start at the beginning and give you an overview of what SBIRT is. So SBIRT is a public health model, and it's really designed for universal screening. Although people have used it in select populations and select groups, select segments of their organization, like just ERs versus everybody in a hospital system. But it really is meant to be universal, and that to me is a key to SBIRT implementation, is to do it universally in your setting. And it's secondary prevention because it detects risky or hazardous substance use before the onset of abuse or dependence. So although if you're screening, you might uncover dependency issues and a person would have to go for further assessment, that is not the primary goal of SBIRT. The primary goal of SBIRT is to detect levels of risk of substance use, whether it's alcohol or drugs, prescription or illicit. And therefore, it can act as an early intervention for people who may be just using in low or moderate risky or even high risky ways who can make changes earlier on in their course of use. Or if people get access to treatment earlier on and they indeed need treatment, then that increases their access and hopefully they can be on the path to recovery. Earlier. Whenever we talk about SBIRT, we always start with the idea of the continuum of use. Let me backtrack 1 second and say that SAMHSA's strategic initiative talks about mental health disorders. We're an addiction technology transfer center, and so I'm just going back to the, I was trying to go back to the slide that had SAMHSA's definition. Oh, here it is, mental health and substance use disorders, and I'm not negating that. I'm just saying our focus is on teaching you SBIRT utilizing screening instruments that detect alcohol and substance use risk, illicit or misuse of prescription medication. Now, there are many SBIRT-like projects that also looked at mental health issues such as depression, but our task is to look at substance use. So that is our focus. I just wanted to clarify that because I had not. So getting back to the continuum of use, so on a spectrum, we look at the use of substances from the blue end of the spectrum here. We, as a society, see that there's positive uses, social uses of substances, casual and non-problematic use, all the way up to problematic use and chronic dependence. So SBIRT has something for everybody along that continuum, and that's what makes it a public health model. I don't think we really ever talk about SBIRT without thinking about the continuum, because that is the key to understand that most of the time when using SBIRT intervention, you'll be looking at people who have maybe very low problematic use up to problematic use, maybe moderate or high, and that is the target audience of SBIRT, not necessarily dependence, although that will too be uncovered and the steps for referral to treatment should be made. Let me check in and see if there's any questions or anything so far. Nope, I see we're up to 41 attendees, but let me keep going. Sometimes I'm asked to talk about SBIRT in like 20 minutes, 10 minutes, and when I do, I go to this slide that you see in front of you. There's 5 steps when thinking about SBIRT, and this is the components of screening and brief intervention, which is the identification of use. misuse, and problematic use with simple, direct, and I should add, reliable and valid screening instruments, the connection of this use to health-related or social conditions, I should have changed that, social issues, the idea of consumption reduction, that people could reduce their use and have positive outcomes just from consumption reduction and not necessarily completely quitting. We do that using a brief intervention technique. And then if the screen indicates, then referral for formal assessment. The screens that we talk about today are not assessments. They're just that. They're screening instruments. And one thing I want to highlight is the identification of use, because any use, even if it's just casual use, when it occurs with maybe a physical condition or some psychosocial situation, might be risky. And so what a screen does is it can shine the light on people's use patterns for you to make that connection to them with their use. And then they can make the decision. Is this something I should reduce or make a change in? All right, I know this is difficult to read. It fills the whole screen up. But I wanted you to see how many valid assessments there are. These are researched and validated screening instruments. So at the very top we have the World Health Organization's ASSIST, and that has been validated with adults 18 and over and been used in mostly primary care settings, but it doesn't necessarily have to. We're using it in a military setting with a project that we're working on. The audit is a 10-question instrument that asks questions about alcohol use, and that has been validated in multiple countries as well as the ASSIST and for multiple audiences. Again, validated for adults. The DAST is to diagnose drug use problems, and all the ASSIST, the audit, or the DAST can be either done through interviews or through a survey. The CRAFT, utilized with adolescents, we'll go over that a little bit when we talk about school settings, and that's been validated for 18 and younger. The CAGE, which is a nice and very brief screen. However, it doesn't really give you, low to moderate risk levels, so you have to keep that in mind as we use the CAGE. The TWEAK, which I know Jim is going to talk about a little bit. And then we have the MAST and the MAST-G and the SMAST, which are both screening instruments that have been validated for the older population, 55 and above. So hopefully you would see on this list that if you didn't know that these screens existed, you do now. And this is one of the key things to understanding SBIRT, is to selecting a good screening instrument that you could embed in your setting, and formally administer and give people feedback on. And surprisingly, this is not well-known information, and that's why we're here today, to shine a light on what we've been researching for the last 20 years. Let me do a time check here. I think I'm doing pretty good on time. The other thing about them, Chris, I saw a couple questions come in, so hopefully you're managing those. I think they were like technical questions. Okay, so that's it about screens. If anybody has a question, please use the raise your hand icon or go ahead and put those in the questions or chat panel. There's other screens. Jim's going to go over a couple more that weren't on my chart. I hope the take-home point is there are validated screens for a variety of settings and populations. They're all evidence-based because they're researched. And also you could see I went back to this slide to show that there are multiple numbers of items. So they can be up to 10 questions or as brief as 3 questions. There's the 3-question version of the audit that's validated. There are 2-question pre-screens that are validated. I see a question came in. So the question was, I would assume to use any of those screenings, one must be trained on them. Well, I would say yes and no. I mean, you could self-train. You could just look up the ASSIST. There's a whole training manual. Probably, most people would rather sit in a training and learn in depth and have opportunities to practice using that instrument, and that's what we do with a lot of our trainings. But you could, as a clinician, go ahead and look at the instrument and find all the information online on how to score it and utilize it. All these instruments are in the public domain. And so you know, I do think that you could self-train yourself on any of these screens. I don't know if Jim or Tracy have a different opinion on that, but I think, you know, what's important to attend a training, what's nice is that you get an opportunity to practice. Because utilizing anything new, you know, you always fumble around and until you get used to it. But I know all of these instruments are available, and they're quite easy to understand. The scoring is quite easy as well.
Yeah, Holly, this is Tracy. I would agree with you. I think folks, you know, can teach themselves how to use some of these tools, but sometimes we have plenty of trainings that have been archived that walk you through how to administer and score them. We can make that link available after the webinar, so you can have 1 to 3 hours of training on multiple tools that might get you started. But I do think if you have the opportunity to practice and work with folks as you're thinking about how to administer the inflection in your voice, the tone, so forth, you really get that either through practicing with a colleague, maybe with clinical supervision, one of the meetings that you might attend on a regular basis with a supervisor, or a live event.
Yeah, I agree. And you just reminded me that you very nicely facilitated a webinar that's in our webinar library that goes in depth about all the screens that you see on this chart right here. And so I think you could create a self-learning opportunity through archived events. And then, you know, I always think it's better to practice. I mentioned that we're using the assist with in a military setting in a project, and we've been practicing it for weeks. And I think that you know, with anything, learning any new skill, practice makes perfect. So thank you, Tracy. Oh, Jim, yes.
Yeah, this is Jim.
And I'm glad you chimed in, you guys, because I feel like I was talking to myself.
Yeah, I sometimes actually do talk to myself, but I think it's the screens can be simple or more complex, and the more complex ones, you know, would require a little bit more study, and the simpler ones less. The other thing, though, to remember about the screens is that they're not diagnostic in and of themselves.
Well, that's true.
They're indicative that there may be problems, and they're also springboards to be able to begin to talk to patients about possible drug and alcohol issues that may be complicating their health. So keeping that perspective, I think people should realize that none of these screens indicate that we can give somebody a diagnosis of addiction.
Right. We have to really keep that at the forefront. In fact, I came up at a workshop I just did last week when people were asking us about confidentiality, and we were like, well, number one, the general environment, especially a hospital setting, has already HIPAA regulations, but you're not diagnosing anything with the screen. It just indicates people's use patterns, and you're giving them feedback about that use. It is not a diagnostic assessment. All right, let me see if there's any other questions come in. I don't see any, but please keep them coming in. This makes it more interesting for everybody. Okay, and then I think somebody had trouble seeing the slide. Hopefully you can see it. And somebody did ask, will we be sending the slides out? And yes, we always send the slides out after the webinar, and we make the recording available if you want to rewatch something, or you could fast forward or rewind. Okay, so let's go on to brief intervention. That's the second component of SBIRT. Sorry about that. That was one of my little pauses. The brief intervention component is based on the concept of motivational interviewing and motivational interviewing techniques. So if you, as most of the people in the audience indicated that you're either a counselor or a social worker, you have probably gone to at least one motivational interviewing workshop, or might be, you know, in-depth training in motivational interviewing through, you know, competency rating scales, which I hope if you're not that you are, because that is a skill that needs to be culled over time. But as far as brief intervention, we do teach, you know, a compressed version of using motivational interviewing techniques to give people feedback, as Jim was saying, as a springboard to a discussion about what their score is on that screening instrument. So here's a four-step process that we talk about with motivational interviewing. You raise the subject with the person. You might say, do you mind if I go over the audit score with you that we just, you know, took together, the survey, or the survey that you filled out in the waiting room? I'd like to talk to you about your score and what that means, providing feedback. asking people what they think of that score and how that score fits into their view of their use of substances or their psychosocial situation that, might be the presenting condition that you're seeing them in. And then through that, based on a person's stage of change and their willingness, enhance their motivation to see what their use levels are and what that means for them, and negotiate and advise after. I'm losing my voice a little bit here. So what is this approach? We use motivational interviewing techniques here excuse me, as part of the brief intervention because we assume that behavior change is fluid, that motivation is fluid, and that behavior change can occur based on people's motivation. In motivational interviewing, the primary goal is to work with people's ambivalence towards changing or making changes and their resistance. So you shouldn't be surprised that people don't want to change or don't think their drinking patterns are a problem, even though they're on psychotropic medications. In fact, that's the norm. And our goal is to evoke and strengthen their personal motivation and want for change. It has to be internal. I mentioned that person's motivation can be gauged by knowing what stage they're in. And so understanding the brief intervention and motivational interviewing techniques means understanding the 5 stages of change model, or the trans-theoretical model of change. So if you haven't been exposed to this, and you came to an SBIRT training, that's something that you would learn about and practice because giving somebody feedback and eliciting their reaction, listening to their response, giving reflective, utilizing reflective listening techniques should tell you, are they in pre-contemplation, they're completely underaware that they have any issue or that their use might be risky, or are they aware of it, yet they haven't been able to make action steps towards changes. Or on the reverse side, maybe they have made changes in the past but haven't been successful with them, and that puts them back into pre-contemplation or contemplation. So this is one of the tenets behind the concept of motivational or brief intervention in the SBIRT model. And then the last piece of the model is referral to treatment, because we always say if you are screening, you may detect people who have high levels of risk that indicate further assessment. And many of the screens will say, give you a zone, a score of high risk in which you would refer people to formal assessment, because we're not assessing anybody with our screening instruments. And we always say that if you're going to start SBIRT, you should absolutely have a connection to referral to treatment process, because that referral to treatment should be meaningful and real to the person. It shouldn't just be a Xerox copy of agencies in the area. It should be a known agency that you hopefully have an established relationship with. Because if a patient has established willingness to talk or open up about their substance use patterns with you, that does transfer over to the next agency. So if they feel engaged with you, that will transfer over to their referral to treatment and help them make that step if that step is needed. It should be something they're likely to utilize, so you should, have some information, a variety of treatment referrals, peer support, online online support, a variety of support services so people can choose what they would like, and then, as I said, a known and trusted provider, because that does transfer. If somebody is engaged talking about their substance use with you and they feel comfortable, that will transfer to that known provider. Let me check in on the panel and see what we got going on. All right, nothing yet. I always end talking about referral to treatment because I can't help but put a plug in for addiction having similar relapse rates as other chronic conditions. So if indeed somebody does have substance use disorder and they've relapsed, that shouldn't be a surprise to anyone, because there are other chronic reoccurring conditions like diabetes, hypertension, and asthma in which people relapse all the time, and we're not punishing them for it. And so we should just help people get the motivation back to a safer level, a more productive level for them if they relapse. And this is a research study of patients who've relapsed, and as you can see, actually drug addiction relapse has better outcome than diabetes and very close to hypertension and asthma. Because change is hard, and it's hard to maintain. All right. So is there any questions? That's the SBIRT model in a nutshell. Is there any questions on the SBIRT model before I go, or comments or reflections before I go on? And Tracy or Jim, did you want to add anything that I might have missed that you were hoping and dying that I said about SBIRT?
I think you're okay.
Okay. Here I go then, a variety of settings. Our first setting we're going to discuss is SBIRT in schools. Now, why should we use SBIRT in schools, many people say? Well, here's a good statistic, that we know that independent people, if, later on in adulthood they have been diagnosed with dependency, they usually initiated use before age 21. And so we know that any time in prevention, and I think there's many people here, I know there's a few people on here from prevention, that we say is you can delay use in children and adolescents, the better outcomes they have for not developing addiction later in life. So, that is the main plug for SBIRT in schools. So how would you do that? I see a hand raised. So, Anita, why don't we go ahead and see? I'm going to unmute her, Chris. I'll do it. And Anita, you're unmuted. Would you like to ask a question or make a point? You can go ahead and speak, hopefully, if you have a mic on your computer. Oh, okay. Maybe that was an accident. So, okay. So let me go on, with schools. So we've been seeing, actually, I would say that this is sort of new but old. SAMHSA has been funding SBIRT cohorts in multiple settings since 2003 through state-funded grants. And in the early cohorts, they did fund college and university SBIRTs. But I would say, now that we've been the national APTC on SBIRT since September of 2012, September of 2013, or no, it's September of 2012, that we have been seeing an increase in training requests from schools to learn SBIRT. And so where could SBIRT be done in schools? Well, in colleges, a good place are their health clinics. And SAMHSA had cohorts in some of their SBIRT-funded grants that have done them in healthcare settings on college campuses and universities. In schools, K through 12, it could be done in a school-based health center if a school has an official health center, or it could be done in SAPs. And I have a good example of that from a place we trained recently. It could be done in a school counseling setting as a routine screen that perhaps anybody coming into this counseling setting, you could administer the craft, or via school nurse. Now let me revisit the SAP thing again, because people are like, well, student assistant programs, if you have them in your state, and I know we have people from all over the country on this webinar, so if you're not familiar with SAPs, you think, wow, that doesn't make sense to me, because if somebody's referred to an SAP, it's because they have a problem or issue already. That may or may not be true. It is true that they have been referred to the SAP, but we don't know what level of problem they may or may not have until we do a formal validated screen. So we have seen an increase in SAP in school systems requesting and sending their school counselors and SAPs to SBIRT trainings. And we have an example of, well, I won't say where, but I'll just say we have an example of a school system that we trained that adopted the craft. They were not using the craft prior to our training, and they said they were routinely doing the craft on anybody who was referred to the student assistant programs, that the students were very receptive to using the instrument and to getting feedback on their use. So, excuse me, that goes back to the slide about a point I was making, that we know that's been research-based, that if you could delay initiating use, reduce use early, that then the adult year outcomes of not developing a dependency issue is, much more positive.
Hey, Holly.
Yes.
This is Tracy. I wanted to add, in addition to with the student assistant programs, we have a couple of folks here who work in EAPs or may be providers on panels for employers. If you think about the workplace in the EAP space, you have schools that at the college level, and some of the universities and colleges will work with an employee assistance program with them like an external vendor, so it's not housed within, say, the school system. But the EAPs administer the program, so they have telephonic call centers and where they're embedding SBIRT, and also working with their affiliate network providers who are the affiliates for the student assistance program that the EAP is actually working with. So just another example of how it even extends beyond the schools that you were even talking about.
That's great. That is great, Tracy. I'm glad you mentioned that. I did not see that. You know what? I lost my panel, so I'm going to go ahead and switch so you guys might see the slide kind of fluttering, but I did that on purpose. That's wonderful. I did not know that connection, so thank you. You know, to me it seems intuitive that schools are a natural place for this. However, you do have to look at the school policies and procedures before you would implement anything like this. But as a prevention and intervention model, it seems like a very likely place, an important place that we could be implementing SBIRT. And we would do that through using one of these two screens up here. Now the craft is a briefer screen, and I think, Jim, you have a slide on this when you're talking about pediatric settings. But it is a behavioral health screening tool for children under the age of 21. It has a recommendation of the American Academy of Pediatrics. And I also have on the slide the POSIT, which is the acronym for Problem-Oriented Screening Instrument for Teenagers. Now, I know this is a bit of a longer instrument. It is still a screening instrument, and it identifies not just substance use problems, but also mental or physical health problems and social relations. It also will ask questions about abuse situations. And a lot of times in a school setting, it's not like a hospital setting, like the ER that's very quick, or like the setting in which there is, you know, not enough time. In the example of the EAP that I met, or sorry, the EAP, the school that is their SAP program decided to adopt the craft. They said that they may do the craft interspersed with an interview with the student, like they'll do a few questions, and it might happen over a couple sessions with the student, but they will complete the whole craft. And on the other end of that, they will give the student feedback about what that score means. So I think that's actually another important component of SBIRT. So these are two screens that can be used in a school setting with young adults and children. Okay, that's what I wanted to say about schools. I don't know if there's anything else anybody else wanted to add or any questions people had. I know, Chris, I'm assuming everybody's seeing and hearing me okay, but I keep getting a message that the audio connectivity might be low on the webinar.
You're sounding fine to me. If anybody else is having problems, please just send a chat or write it in the questions box. But it hasn't dropped off at all that I've heard.
Oh, good. All right. I am using a laptop, so who knows? Maybe it's overwhelming my laptop, all this functions. Okay, well, I'll move on to SBIRT and behavioral health settings. But, you know, if you have a question or thought about school settings, you can go right ahead and ask that. And I also want to do a time check. Okay. Here we go, community mental health settings. Psychological practice, you know, psychologist practices, private practices, group practices. Believe it or not, I'm sure your mental health facility might do a screen, but many do not. Many do not ask questions about drug and alcohol use, and if they don't, if they do ask, they may not use a validated screen. They might just ask, do you use drug or, alcohol or drugs? You know, we know through research of these instruments that there's a better way to ask. These are researched ways of asking the questions, and it's more likely to elicit an honest response. So we've done SBIRT training for mental health practitioners. And then domestic violence centers or other community centers like that could also be adopting screening methods because we know there is a correlation between these settings and the negative impacts of using, even in a low-risk way, alcohol or substances. So one of the major areas of mental health, of course, is co-occurring disorders. So you see a couple statistics on the PowerPoint about, how many millions of people have co-occurring disorders, which means they have both a mental health and substance use disorder. But only 7.4% of that 8.9 million receive treatment for both conditions. And it was just illustrated in a conference that I was at a week ago that people still have the siloed experience. If they're going to a mental health clinic for a mental health issue, they are only getting that kind of treatment or therapy, and people are not talking about their alcohol or substance use or their nicotine use, for that matter. And so this is something we can change. And even if a person is not co-occurring, maybe they have a mental health condition like depression or anxiety, just their use, even low-risk use of substances like alcohol, our great American, society love affair with alcohol, is not, is a high-risk use of alcohol if they're on psychiatric medications. It could be lessening their positive outcomes of treatment if they're using even in a low-risk way. So that's the case for, in mental health settings, assessing people's levels of use so that you can make connections with them about their risks. So let's look a little bit further about alcohol use. Like I was saying, we have this, connectivity as a society with alcohol, and yet we leave, alcohol responsible use messages up to the industry itself, and we don't really address this as a public awareness issue, that there are low and moderate levels of use, and there are situations in which no use is safe or healthy. And so I would make the case that in mental health issue, if you are getting treatment for mental health situations, that alcohol can impede your progress towards your mental health, recovery from mental health issues. And these statistics, underscore that 30% compared to 24% of adults with no mental illness, those who have mental illness are more likely to use alcohol in a binge way, which is 5 or more drinks on one occasion. And those with mental health illnesses also have reported heavy alcohol use. So just if you're in a mental health clinic, you really should consider just adopting an alcohol screen, just from the fact that it could be impeding people's progress. Even, low risk, once a month I just drink 5 drinks at a football game, could be impeding their progress. And it's a worthy way of implementing SBIRT in a mental health setting. All right, I'm checking in. I guess we're plugging away here.
Holly, just one other comment about the mental health setting.
Oh, sure.
Often people who are being seen at mental health clinics are on medications which may interact with alcohol, or alcohol may interact with those medications in ways that are very risky for patients. And I think a clear discussion of that with patients. It's not enough for them just to see something on the label of their medication that they get from the pharmacist, but a clear discussion of the risks involved in drinking on medications, or how it's going to affect the effectiveness of those medications, or other risks it may pose for the patient, can be a useful discussion, even if the patient doesn't appear to be drinking at a risky level with regard to the drinking itself. But if they're on a medication, that complicates things.
Yeah, I did mention psychotropic medications. And could I add that if you adopt an alcohol screen, then you're giving concrete feedback about their alcohol use. You can let them know what their score is, and then compare that risk and say, well, you may be at a higher risk because you're on antidepressant medication or anti-anxiety medication. Anything else? Anybody have any questions, comments, or feedback? Hopefully, if you are in a mental health clinic, you are asking, questions about drug and alcohol use, and providing the opportunity for patients to make that connection to their mental wellness along with their substance use patterns, even smoking and nicotine. We did not have the screen on there, but there are screens for, nicotine dependence, and you could certainly put that into the modality of looking at people's use of nicotine. All right, I'm going to move on to SBIRT in military settings. So this is near and dear to my heart because we are currently working on a couple projects with regards to SBIRT. And so we know that in military health settings that they do ask questions about, drug and alcohol use. We also know that they drug test. Obviously, certain jobs in the military require, people to be drug-free. And not just active military, but also the National Guard services and ROTC, could be an opportunity, and that's kind of similar along the lines with SBIRT in schools. It's an opportunity to, earlier on, while they're in their training, to talk about and fully effectively utilize SBIRT to increase their awareness of their alcohol and potential substance use or misuse of prescription medications. So why is this important? Here's some statistics. This just was released in 2012, and there's a link to the report at the bottom of this very busy slide, that the U.S. military, and not just the U.S. military, I already said this once, I'll say it again, we have a love affair with alcohol in the U.S. society. And the military is no different. We have a long history of alcohol use, and it's ingrained in the culture. Perhaps a unit abstains, and then when they get back from a mission, one of the primary ways that we celebrate is by going out and getting wasted. But it is, for some people, initiating a longer course of addiction for them, and just in thinking of alcohol alone. So the U.S. Department of Defense did ask the Institute of Medicine to develop a report on their concern about alcohol misuse and abuse, and also the increase of prescription drug abuse among service members. So they recognized this issue, and they did ask the IOM to make recommendations, which you could review with this report, because they are concerned that they're seeing very high use of alcohol in particular and prescription drug abuse in the armed services. So it's an important, oops, I thought I had one more slide there. But I want to, I thought I had a slide. I wanted to go back to and tell you about what projects we're working on. And I know, Tracy, you have a couple of projects you're working on with the military. But two in particular, the National Guard and also ROTC. We had a project that did not get funded, but we're still going to continue to try to get funded, in which we are teaching the SBIRT model, model I just reviewed, to the Army leadership, because ROTC members will become leaders within the Army, and to also teach it at large to the ROTC cadets. So, so that they could identify in their peers perhaps problematic use, and also utilize motivational interviewing techniques when they become leaders in the military, as well as benefit from the SBIRT model as active ROTC members. The other project that we are actually working on is utilizing SBIRT in the Army National Guard setting, and they have elected to use the ASSIST, which I showed on that busy chart. And the ASSIST, the nice thing about the ASSIST is it does screen for alcohol, drug, illicit and prescription, and tobacco use. And so you can give very concrete feedback on the levels of use around alcohol and illicit drugs. You would think that people in the military services don't use illicit drugs, but that is not always the case. So, but how do we tackle the alcohol question in the Army, in the, any of the armed service branches is a big issue, and one that we think SBIRT can readily make inroads, especially when their use is low to moderate use, and they have the opportunity through brief intervention to make changes. So that's why it's worthwhile to use in these settings. I don't know, Tracy, did you want to add?
Yeah.
I know you have a couple examples.
Yeah, thank you, Holly, and maybe you can let your voice for a few minutes. Yeah, we've really been working to pull in leaders from the military health professional groups who can really inform us about how do we adapt training, how do we develop military relevant materials, whether that be in live trainings, webinar trainings, print materials, or what we were really excited about is in the development of a training program that would be specifically designed for the military and military situations, military clinical settings, both behavioral health, primary care, and really to give it the look and the feel and the sense that these are real cases, complex cases that military health professionals see every day. And the training will utilize artificial intelligence and natural language processing kinds of technologies, and to really give the opportunity to the military health professional to practice and to learn about how SBIRT is translated into the military, because we think it's very important for us to recognize when you're not in the military that if you're going to adapt it and make it relevant and have an impact, it really needs to be, it's not just something you can snap in to a military setting. It really needs to feel like what those professionals live and breathe every day. So we're really excited about that work and hope to roll that out by the end of the year.
That's a good point. In the training, and because this is just a new project, I won't state what state or anything like that, but in our recent experience with the Army National Guard, that it is, we invited them to attend the training, and that was instrumental because they could connect with the provider system. In that setting, the Army National Guard members go in and out of the community and into the Army setting. So, you know, they're pretty vulnerable to lots of influences and stressors. And we wanted to make sure that we were communicating with both worlds and adapting SBIRT, you know, so that it could fit the Army National Guard. On the other side, you know, just having the idea that the Department of Defense and the Armed Services want to tackle this issue, you know, by asking the I wanted to go back. With the IOM report, shows a willingness to do things a little bit differently. It's not just a punitive path. There are opportunities, and this is the key of SBIRT through brief interventions, for people to make changes earlier on in their course of use so that they can offset, you know, longer-term consequences. And so we're really excited to be applying SBIRT. And you're so right, Tracy, to have there's cultural adaptations of the model that has to fit the military culture.
There's one other thing that's really interesting that's going on that, you know, as I learn about how our veterans return, and they may be in the reserves, and then they have certain services that are available to them after they return. But after a certain period, you know, many are really expected to integrate into sort of civil life and to use resources that are non-military resources. So one of the things we're trying to do is work with the employee assistance programs, with workplaces, with providers who are on affiliate panels, working with managed behavioral health care companies who have contracts to provide military behavioral health services, to work with them to integrate SBIRT in an adapted, culturally appropriate way. And so I think that's another really important piece that all of us and many of us on this call probably encounter military men and women, but they may not be under the services that are really available under the military necessarily. And that's just important for us to keep in mind.
And recognize. In fact, one of the state grantees asked that demographic question because sometimes in different community settings, a former military member, a veteran, will not identify themselves as a veteran unless asked.
Right.
So it's an important concept. Hey, you know what, Jim and Tracy, I've taken us right up to 2 o'clock, and Jim will let you be the decider. We were going to take a little break at this point. Do you want to take a break here? Or do you want to cover a few of your slides?
Why don't we cover just a few, and maybe we can take our break at 2:15. Does that seem reasonable?
That's up to you. That sounds good. Here, I'll make you the presenter.
Okay.
And you should see this thing, and then you can pick up from your slide.
Right, on my screen. Okay. And we should be ready to go.
All right.
Okay. Thank you very much, Holly, and
I'll be on until for a little while.
Okay, good, and please feel free to, to interject so that we can get as much information out as possible as we go through this overview. I realize it is a lot maybe for an audience to digest as we go through these various settings, but I think the purpose is to understand SBIRT's utility in many different arenas that we may not think of SBIRT being in. However, the healthcare settings are areas where SBIRT has been most used and primarily used, especially in its beginnings. So we're going to talk about a variety of healthcare settings, as you can see there, from emergency rooms and trauma centers all the way down through STD clinics, and have a few words to say about each of those. If you have any comments going through, please go ahead and interject them or ask a question. And Tracy and Holly, obviously, if you have anything to say as we're going along, please do so. We're going to begin just with this kind of older diagram, which is sometimes useful to show to patients. It is showing its age a little bit, but this particular slide shows a nondescript picture of a characterization of a human being, and it shows all of the different areas where high-risk drinking can cause problems from head literally to toe. And sometimes it's useful, I think, for patients to see something and not just hear us talk about things. As we begin to describe for them some of the risks that their drinking may be presenting for them based on the health concerns that they're bringing to various healthcare settings. And so a useful diagram like this can be helpful, I think, in making it clear to patients that if they're drinking in a high-risk manner, they are likely to be affecting their bodies in ways that they may not even be aware of. And I think that sometimes as healthcare folks ourselves, whether that's behavioral healthcare people or people involved in primary physical health, we take for granted that patients kind of know things that they may not know. And so it's useful, I think, to be sometimes explicit with people in terms of the harm that they may be doing themselves by drinking at high-risk levels, and this little diagram can help illustrate that for them. And it's important that these are facts that you may be generally aware of, but sometimes, again, we can almost get jaded as we see statistics like this, that alcohol is the third leading cause of preventable death in the U.S. That's 76,000 deaths, or 5% of all deaths in the year 2001. If we stop to think about a number like 76,000 deaths that could be preventable, and we know how upset we get, and rightly so, when we hear about natural disasters or attacks by terrorists that result in sometimes hundreds of deaths, and even in some cases in excess of 1,000 deaths. And yet we can see a number like this, and it's kind of routine. Oh, okay, that just happens. But each one of these 76,000 people were human beings, and their deaths could have been prevented if they had accurate information about how their alcohol use was affecting them. And we can see even globally the number is much higher, according to the World Health Organization, 2.5 million deaths per year. So a lot of deaths and a reduction in quality of life, the middle bullet there, reduction in life quality, these are results that we can have an impact on if we only take the time to do the screening and brief intervention that SBIRT suggests that we do. We talked a little bit earlier with regard to behavioral health, but one of the things, again, that people may be naive about, as healthcare professionals maybe not so much, is the way that alcohol interacts with many medications. A colleague of mine, I got a call in a little bit of a panic from a friend of hers one day, and this gentleman had been out the night before, and he said to her, honest, I only had a couple glasses of wine and I passed out. And he was a little panicky, wondering what could be going on here. Well, she remembered that earlier on, this particular person had told her that he was going to be scheduled for dental surgery at the dentist's office. And so she said to him, remember when you talked about that dental surgery? When did you ever have that done? And he said, yes. And she said, when? And he said, yesterday. And you know where this is going. And she said, well, after the surgery, did the dentist prescribe any medication? And he said, well, yeah. Well, what was that, says she. And he said, well, Vicodin. Well, did you take any before you went to the party? Well, yeah, I was in pain, so I took a Vicodin. So despite the fact that I'm sure there was a big red warning sign on his bottle of Vicodin, he went ahead and took a Vicodin and went out to the party and drank on top of it. And so people can be very naive. People who may not even have serious or risky drinking patterns need to be informed about the interaction that alcohol can have with medication, and obviously how it can exacerbate various medical conditions. So this is good information to be passing on in healthcare settings. And again, these other kinds of conditions that many of you are aware of that can result in long-term alcohol use, are things that people may certainly not be aware of as well. Now, let's begin with emergency rooms and trauma centers, because this is an arena where SBIRT is being used and can be used effectively. But I need to say, I guess, at the outset, that implementation of SBIRT in these settings is not for the faint of heart. Emergency rooms and trauma centers are extremely busy places that are primarily focused on acute events, people coming in for treatment of something that needs to be taken care of right away. And so the public health perspective that SBIRT usually brings along with it doesn't necessarily find a natural home in emergency rooms and trauma centers. And yet you can see here how important it would be to insert SBIRT into these settings because of the high number of patients who test positive for alcohol use in these settings. And in fact, right now, not very many trauma surgeons or other people associated with emergency departments are screening patients for their alcohol problems. So we have a kind of a don't ask, don't tell approach. And as I say, because these settings are so busy and so complex, sometimes it can get lost, the idea that it would be important to screen people for whether or not they may be using alcohol at risky levels, despite the fact that there are many reasons why we should screen in emergency departments and trauma centers, as you can see there. One of the things that I think is important to always emphasize with SBIRT is the reason why studies have shown it is effective is because people who aren't dependent on alcohol can cut back on their drinking. Obviously, if we're talking about the smaller number of folks that are actually dependent on alcohol, about 3 to 5% of the population, that's a different question, and the answer for those folks is usually abstinence. But many people can cut back on their drinking, and obviously a visit to the emergency department or a trauma center can be a situation which gets people's attention. They may not have connected their drinking to their reason for coming into the trauma center. And that can be because the trauma they've experienced is what's primarily on their mind. But to step back and take a look at why the trauma occurred or what the connection could be between drinking and alcohol use can be useful in these settings. Now, as I said earlier, implementation in these settings can be very, very difficult because of many obstacles exist. I think it's important if we talk about implementation in these settings, and if an emergency department or a trauma center is trying to implement SBIRT, that a considerable amount of time and discussion be devoted to how this is going to be done. What are the realistic parameters that we can set up here that will ensure that SBIRT will be done in this setting? And that takes some time. Sometimes if we go in too soon with the training about what SBIRT is and how to do an SBIRT intervention, and we haven't taken the time to step back and say, well, how are we really going to do this in this setting, then it can be counterproductive. People get frustrated or feel like this is just another thing they're asking us to do, amidst 1,000 other things we have to do in our setting, and how is this really going to happen? So the first thing, obviously, is a good case has to be made and can be made for SBIRT in this setting. And also, we want to make sure that the right people are involved in organizing the project, including people in the trenches, people who understand the issues that do need to be addressed if implementation is going to be successful. And we need to work toward that common understanding of how the project's going to work. we should decide on who will provide the intervention. So there's screening, and that can be done relatively quickly and maybe even as a routine part of a triage in these settings. But then if an intervention is indicated, who's going to do that? Who are going to be screened? What's the screening procedure going to look like? Where is it going to happen? And we need to be clear about all those procedures. And also, what if a person does need a referral to treatment? How are we going to develop an efficient way to make a referral in that very busy setting? And how are we going to develop a sustainability plan beyond the initial push to implement SBIRT in that setting? And the 10th thing there is something that I think is useful for people who are struggling to implement SBIRT in emergency departments, trauma centers, and even hospital settings in general. There's an excellent learning community at this website, hospitalsbirt.webs.com. You should go there and sign up and be part of this learning community. If you're planning to do an implementation of an SBIRT project in your ED, trauma center, or hospital, get some support, have a place to talk about any issues that might come up. And I don't know, Tracy, if you have any thoughts. I know you're going to talk a little bit about the website later, but if you have any thoughts at this point about its utility, you can type out.
Sure. Yeah, I mean, all of the things that are available to you on the hospitalsbirt.webs.com website are publicly available and free, and we've brought some excellent speakers and have archived and made those available to you that give examples of real-world implementation, their challenges, their suggestions, their lessons learned, their successes, outcomes, whether you're talking about if you're, let's say, an addiction treatment provider working with a hospital, how do you do that well in your community? If you're working with women of childbearing age and pregnant women within a hospital, there are very specific examples, and there are also webinars that sort of highlight multiple examples in one, and you can kind of fast forward to the ones that really resonate with you. But there's a lot of good archive material there in that form, as well as articles and resources that basically what we tried to do was pull together in one place some of the leading materials so that you don't have to go and search all over the web. So that's kind of like a portal for doing that. And then if you sign up, we have a approximately monthly webinar series and highlight thought leaders and in the field, as well as practical implementations on some of these calls. And you basically, it's a learning community to share and learn about what others are doing. And within that group, we also have a TA group that meets maybe quarterly or so to really talk about specific implementation in their site. So hopefully you will go to our website.
Can I break in a second?
Sure, Holly.
First, Chris, I know somebody said they lost sound, so if you could look at the questions panel and answer their question. And then, Jim, you do have a question about before the break, if you could address it.
Sure. Can you, let me see if I can pull up the question.
Well, I can read it to you. I just didn't know if you were going to break there. I'm sorry to interrupt, but I noticed, I hope nobody else lost sound, but one of our listeners did, so maybe, Chris, you could look into that, a technical issue. And then the question, Jim, that came on the question board was, can you elaborate, Chris gave the example of W.C. Fields, but again, could you elaborate on the drinker's nose and what that means? So you can go back maybe to that slide.
Okay, the drinker's nose. Did we talk about, yeah, on the
yeah, it's on the anatomy guy.
Yeah, right. Yeah, drinker's nose is a chronic drinker, usually somebody who is pretty seriously involved in alcohol, can develop a kind of breakage of the blood vessels in the nose that gives them a very red nose, and W.C. Fields, I suppose, is a good example. So this is what drinker's nose is.
Although we should say as a disclaimer, we do not know if he was diagnosed.
Right, no, we're not using the word alcoholic here. And, I'm saying it can be a sign. There may be other reasons, but it can be something that happens to people who are pretty seriously involved with alcohol and may be dependent. But But that's what it is. It's the breaking of those blood vessels that gives that nose kind of a slight enlargement and a little bit of a red cast.
And we should also mention there is some controversy over this, that when you mentioned, Jim, that it's outdated, it's showing its date, because there is controversy suggesting that that condition is most likely caused by other things, and it may be connected with rosacea and sunlight and other things. And so we just caution people not to sort of stereotype or jump, kind of that conclusion. But there is controversy over that for sure.
And that's a good caveat. You can't diagnose a person by looking at them. So you don't know what else might be going on. However, that can be one of the causes of that condition, but it's not the only one. Even cirrhosis of the liver, can have other causes besides drinking. So we have to be very cautious in diagnosing or thinking we can just look at somebody and know what's going on with them, because usually we can't, not only with drinking, but with all kinds of other things as well. So those are good cautionary statements. Okay, any other questions or concerns?
I don't see any more on the panel.
Okay, well,
go ahead.
Okay, well, so this probably would be a good time to break, and just let me, again say that to those of you that may be in emergency department settings or whatever, just, I think preparation is the way to go. With, I'm kind of frozen here for some reason. My next slide. I don't know. Oh, there we go. Okay, so there are resources out there for you. The Committee on Trauma has excellent resources if you are interested in implementing in those settings. This is just the Committee on Trauma quick guide, which gives you information about how to do screening and brief intervention. They have another publication that is certainly worth looking at called a step-by-step implementation guide for trauma centers. It can take you through in some detail how you might be able to implement an SBIRT program in your trauma center and also in emergency departments as well. It's an excellent resource called a step-by-step implementation guide for trauma centers. And the idea that was, I don't know, some of you older folks might remember Ross Perot, an old presidential candidate from the 90s, used to say, measure twice, cut once. And I think that's good advice when it comes to preparing to do an SBIRT protocol in these very busy settings, is do a lot of preparation and then go ahead and do your protocol, and you'll have more success if you put the time in to figure out how you're going to do it properly. So why don't we take a break there and reassemble at 2:30. Everybody can take a little stretch, and we'll be back at 2:30. Does that seem reasonable? Fellow presenters here today?
Sounds good to me.
Okie dokie. We'll see you at 3:30 or 2:30. I'm sorry, 2:30 Eastern Time.
Hi, everybody. I guess we're getting ready to start again, so I will turn this back over to Jim.
Hey, Chris and Jim, we have a couple questions. My question is, on a phone panel, Chris, do you know what you type in to manually mute the phone?
My phone?
No, I mean any phone. Is it *6 or?
Oh, I don't know if it's the same with these new phones as it was for the old ones.
No. Well, just from this panel, is there a function to mute? So if you could look that up and then text, send it to the chat function to me.
Sure.
Okay, and because I had asked in the chat to you, but I don't think you saw it. Then, Jim, there is a question for you. And I was going through the slides, and I wasn't sure you were going to specifically address this, so we'll just ask. Jim, are you there?
I'll see. Maybe he's...
Oh, you might be muted, Jim.
Yeah, I'm unmuted now.
There we go.
That helps. Speaking of muting, there was a question, were you planning on discussing application in the OBGYN setting?
Yes, I see that question.
I thought I saw the tweak. Okay.
Yeah. No, we'll be talking about the TAs and the 4 Ps, actually.
Oh, okay.
Yeah. But yeah, I'll be talking about that.
All right. That was all the questions I saw come in on the questions panel.
Okay. That sounds good.
It's over to you, Jim.
Okie dokie. Let me see here. Okay. So just one last word, I guess, about the CAUT quick guide that I have up there on the screen, and more importantly, the step-by-step implementation guide, which is also available, through the Committee on Trauma, the American College of Surgeons Committee on Trauma. This is a good guide for implementation of SBIRT in many different settings, so it is worth looking at if you get the opportunity. Okay, let's continue then. Maybe we'll continue. I seem to have a little freeze up here. Here we go. Okay, let's move on then to primary care and federally qualified health centers. And again, we have kind of a don't ask, don't tell approach when it comes to identifying alcohol and drug problems in these settings as well. You can see there that the study says that about only 29% of patients reported being asked about their use of alcohol or drugs in the past year in this particular study. So a fairly small, about a third of patients get questions about their alcohol or drug use, and so that's problematic in the sense that we should really try to get that number up. And obviously, management of alcohol misuse is very important in these settings. First of all, regular contact with the patient. The most regular contact is in these settings where people are accustomed to go on a regular, more routine basis. And there is a prevalence of alcohol use or misuse, as we know. We were talking to a federally qualified health center in Ohio recently where the leader of that center, Dr. Ron Dwinells, has instituted the SBIRT protocol, and he calls alcohol screening a vital sign. So just when you're going to the primary care center or the FQHC, they're going to take your temperature, they're going to weigh you, they take your blood pressure, and he has instructed his staff that another vital sign is going to be doing an alcohol screen on patients when they come in for routine reasons. And I thought that was a very good way to look at it, that this is something that's that important that we could actually call it a vital sign. Obviously, if we don't investigate this, a person's alcohol use can be a barrier to the treatment of chronic conditions, and there are certain cost and time-saving benefits to doing screening and understanding the role that alcohol plays in a person's life with regard to their health. And then we have the potential for effective intervention in these settings. So primary care settings, FQHCs, can be very important places to implement SBIRT. And the question often comes up almost as a barrier as to, well, we don't want to get patients upset by asking them about their drinking. And this is a curious question in some ways, and but it's something that we hear quite a bit, that we may alienate a patient, we may disrupt the patient practitioner relationship in some way, some people may feel like, well, I drink. Why am I asking my patients if they drink or about their drinking? Who knows what could go into that reluctance? But the reluctance is real, and it exists, that patients are somehow going to have a negative reaction if we ask them about their drinking. And yet, we can see in this study, which was quite a large one, called the Cutting Back Study, done by the University of Connecticut. It was a large study, and here's what we see, that patients have a sense of importance about screening for these conditions or these areas. Diet, they expect that it is important for practitioners in health settings to ask them about their diet and exercise. Smoking, they think that's important, and drinking. So patients in pretty high levels feel that it's an important question to ask about their drinking, either important or very important, as we can see from this particular graph. There are some who feel it's very unimportant or less important, but that's a very small number. Actually, less than 10% gave that response. And in terms of their comfort with being asked these questions, we can see that most patients are either comfortable or very comfortable being asked about these questions in a healthcare setting. They're not put off, that their healthcare provider would be interested in their diet, their smoking habits, or their drinking habits. They are expecting that these lifestyle issues are going to come up, and they're not uncomfortable. Sometimes it's more the practitioner's comfort level that's at issue here rather than the patient's comfort level. And again, we see a very low number, less than 10%, are uncomfortable or very uncomfortable being asked these questions. So we shouldn't let this be a barrier toward asking questions about alcohol use, because the patients themselves are expecting that these questions are both important and that they're comfortable being asked these questions. Overwhelmingly, they're comfortable, and only a few patients are expressing discomfort. Now, that was a quick visit through primary care and FQHCs. Those are settings where SBIRT has been studied quite a bit, and when we hear about the effectiveness of SBIRT, it's often in relation to those settings. But there are other settings that it's appropriate to use SBIRT. We know that the pediatrician's office is a good place for questions to be asked about alcohol use and other drug use. We can see on the screen now how many young people use illicit drugs and how many young folks drink. And the fact that there are approximately 6.6 million binge drinkers and 2.1 million heavy drinkers among this age group of 12 to 20, and those are significant numbers which really require us to ask these questions in the pediatrician's office. Now, I know some of you may be familiar with the fact that the U.S. Preventive Services Task Force has endorsed SBIRT and recommends that clinicians screen adults age 18 or older for alcohol misuse and provide interventions. They are not in a position to recommend this for adolescents only because sufficient research has not been done, but they certainly understand that alcohol use or misuse among adolescents is an important public health problem, and that SBIRT can play a role there, even though maybe not enough research has been done yet to show the efficacy of SBIRT with this population. And I think it's important to remember that research is expensive and complicated to do, and it would be great, and probably will come at some point, that we'll have more extensive research on the use of SBIRT with the adolescent population. But that doesn't preclude us from using SBIRT with this population now in the pediatrician's office. So we want to know these facts, that alcohol is by far the drug of choice among youth. A lot of times we can get, I guess, sidetracked, not really sidetracked, but there's a lot of drugs, obviously, that kids get involved with, which are very dangerous. Everything from marijuana to inhalants, all kinds of drug experimentation is going on with this population. But we shouldn't lose sight of the fact that alcohol is by far the drug of choice among youth. And so that's an important fact to remember. And we can see there in the third bullet there that the proportion of kids who drank in the previous year rises tenfold from 7% of 12-year-olds to nearly 70% of 18-year-olds. So it goes up as the kids get older. Binge drinking is a big problem with this age group. And you can see in the last bullet, 1 in 14 8th graders and 1 in 6 10th graders, or 1 in 4 12th graders report having 5 or more drinks in a row and are binge drinking. These are very dangerous statistics for this population, as you can well imagine. So it can be very useful for the pediatrician to do the screening and to to ask the questions of their younger patients. Pediatricians can be trusted, and I think that young patients are a little bit in awe of doctors in some way and of their pediatricians, but also respect them and maybe will listen to the pediatrician in a way that they won't listen to parents or even school counselors and folks like that. So there's a small but growing literature around the brief interventions with this population, and you can see that the initial research is showing positive results there.
Jim, we do have a hand raised. I don't know.
Oh, I'm sorry.
Question from, or if that person just inadvertently.
Okay.
Is it Tammy? I'm going to go ahead and unmute you. You could go ahead and ask a question. Tammy?
It's Tim from Colorado, and he also typed it in.
Oh, okay. Go ahead and read it then.
Sure.
Yeah, go ahead, Chris.
In Colorado, we have legal marijuana. Given the statistics represented in the previous slide, what is your recommendation for clinicians in this state and approach to intervention if marijuana is being used legally in home environments by parents, care providers? It's difficult to present to youth that use of marijuana can be problematic. Suggestions are welcome.
Yeah. Well, that's a very good question, and it's probably one that's going to be soon, to be exported to many other states.
Are there low-risk marijuana level uses? We have.
Yeah, I don't know that we've developed that as much, right? I mean, we know the NIAAA points out the risk factors involved with various amounts of alcohol intake.
Right.
But with marijuana, but I think that in general what we can say is, look, alcohol is also legal. They're going to be in their homes where their parents drink, and sometimes drink beyond the levels that are recommended by the NIAAA. The issue for kids is information about how their marijuana use may be affecting their health or their other behaviors, their schoolwork, et cetera, things like that. So I don't think that we can, we have to deviate too much from what we might have said before marijuana was legal in those settings. There's a lot of things that are legal but harmful. And I think that what we need to do with adolescents is to give them information in a dispassionate way to discuss how they're using the drug, if they are, and what risks it may present for them. And using good principles of motivational interviewing. What do you like about using marijuana? What are some of the downsides you've experienced? Remember, our patients are going to make the decisions for themselves. What we can do is present them with good, accurate information, engage them in a discussion, get them to think about whether the way they're using marijuana or any other substance is affecting their lives, what are the upsides and the downsides, and maybe begin to make some choices around changing their behavior. I realize right now, probably in Colorado, there's kind of, no pun intended, a little euphoria going on around the legalization of marijuana. But as things settle down, hopefully rational discussions can take place. But you are challenged, I think, by this new change in legislation. I don't know, Holly or Tracy, do you have any other insights that we could offer?
Well, that's similar feedback that I would give, and I would say that one resource for you in Colorado, which is an exemplary resource for learning more about how SBIRT is being implemented and how they're handling these kinds of issues, is to go to the SBIRT Colorado website, which is improving. I have it on one of my slides. You'll see it later on. It's the Improving Health Colorado website, and they have a lot of resources, and something that they also are having to work with in this new context, and maybe there's some ideas there to help you think about how you might do it in your own organization. What kind of feedback, what would that brief intervention protocol look like and feel like? What would go into that to really effectively address it?
Yeah, there are great websites out in Colorado there. So, and you'll be talking about those a little later, right, Tracy?
I will have a link. I will have a link to their site.
Right. Okay. All right. Well, let's move on a little bit here and see if we can continue. And there are other implementation considerations when you're talking about the pediatrician's office. Obviously, parents can certainly be notified that it's going to be common practice in the pediatrician's office to ask young patients about their alcohol and drug use. And the screening that Holly talked about, the use of the craft, and we'll give you a resource where the craft can be located in a minute. Confidentiality, these are things that the practice needs to think about and according to their own policies and procedures when they're talking to young patients about anything, whether it's their sexual practices or whatever, what are the limits of confidentiality that are in keeping with the law and with the practice of the particular pediatrician's office. And obviously responding to other things that may be beyond the boundaries of confidentiality, suicide being obviously one of them, that there can't be any confidentiality if a young person begins to talk about suicide in terms of notifying parents, etc. So some things to consider if you're in the pediatrician's office. Okay, let me see. I cannot close that up, and I'll be able to do it. Can't do that. Okay. Now, the American Academy of Pediatrics is recommending that pediatricians provide alcohol screening and counseling to all adolescents and children in upper elementary grades. So they understand the importance of this. And obviously, pediatricians, as we said earlier, are uniquely positioned to influence their young patients because I think they are respected and even maybe held in a little bit of awe. And also, I think that young patients feel in some ways that they can share their thoughts and even their anxieties with their pediatrician. Usually, pediatricians are youth-friendly. They know how to set up rapport with their young patients, and that makes it easier for young patients to talk with them. Now, this is a very good resource available for pediatric practitioners and, I should say, others, not just pediatricians. It can be useful for any of you that deal with youth to get this resource from the NIAAA, Alcohol Screening and Brief Intervention for Youth, a Practitioner's Guide. This has been produced in cooperation with collaboration with the American Academy of Pediatrics, and it contains a lot of information about talking even to very young children, as young as 9 or 10, about their alcohol use, and also includes the craft. The craft is in here. The questions that the craft asks are in this resource, so those would be available to you, as well as some other screens that they recommend, briefer screens. So this is an excellent resource available for download, or you can order the hard copies of these at no cost from the NIAAA. Okay, let's move on to dental clinics. We want to talk about dental clinics as a very good locus for SBIRT. Obviously, there's a relationship between substance use and oral health. And this is something maybe we don't think about as much as we should, but there certainly is that relationship. And dentists are in a position, I think, to address this. The other thing is that dentists and oral surgeons prescribe approximately 12% of immediate-release opioid-based prescription medications in the U.S. So this can be very problematic if the dentist is not keen in enough to do screening, alcohol and drug screening. I had a little experience a number of years ago, this is going back a few years now, where I was sitting in my office one Friday afternoon and I chipped a tooth somehow. I don't know, I bit into something. And in order just to relieve my discomfort over the weekend, I called my dentist to see if he could file down the tooth. He wasn't available, so I decided to go up to the mall dentist. So I went up to the mall and walked into the walk-in dental clinic up at the mall, and he filed down the tooth. I wasn't in pain. It felt okay. But before I could leave the office, he whipped out his prescription pad and wrote me a prescription for Percocet and handed it to me. And, you know, I said, no, I don't need that prescription. I'm feeling okay. If I have any trouble, I'll just take some Tylenol. So he took it back and tore it up and said, well, I hate to see people in pain. So he wrote me another prescription for Tylenol 3 with codeine. And so I practically had to restrain him from giving me a prescription. And the thing was, he never asked me any screening questions about my alcohol or drug use. So it's really important, I think, for dentists to get into the habit, and they're probably more in the habit now than they were back in those days, to ask screening questions so that they understand, you know, how their patients are using alcohol or other drugs before they give them any prescriptions. There's a lot of association with cancers, esophageal cancers in drinking, cancers of the mouth, larynx, and pharynx, other kinds of cancers. Obviously, those of you in areas where methamphetamines are used are familiar with the meth mouth phenomenon, and something that you may be more familiar with because you deal with those populations. You see things like this if you're a dentist with people who are using methamphetamines. It affects the enamel of the teeth. Not a pretty picture as it progresses. There are other kinds of abrasions on the tongue or throat that are problematic, the esophagus. And then we have this phenomenon where you can see somebody who has, in 2000, looked that way, and as their meth use progressed to 2004, and oh my gosh, they may turn into Steve Buscemi if they keep using. One of my colleagues thought that was kind of an interesting progression there, but at least the first two are accurate ones. So moving along. So again, we see a lot of prescriptions are written by dentists. There's the drug and drug interaction, which can be problematic in dental clinics. And so I think it's reasonable to think that dentists, dental offices can be places where SBIRT can have a home. The dentist can take the time early on to do a brief screen and to be able to do an intervention as well. Dentists can do very successful interventions. I sometimes use my own story where a dentist did an intervention with me around flossing. He would ask me routinely when I would go in for cleanings, hey, do you floss regularly? And I would say, well, not as regularly as I should, meaning I really never flossed. I have pretty good dental health, and it never seemed to be an issue for me. Well, he took the time to let me know there was a connection between gum disease and heart disease. And if I took the time to floss, I could lower my risk for heart disease. Well, that moved me from the pre-contemplation phase about this whole flossing issue to the contemplation phase, and then eventually resulted in me changing my habits around flossing. And so you could see that a dentist could do the same around alcohol or drug use. A simple screen, a little bit of conversation about the effects that drinking or drug use might be having on the person's oral health. Dentists often have the time to do that and certainly have the ability and the location to do that. One area that can be problematic in some dental clinics especially is the privacy area, making sure that there's enough privacy so that a conversation like that could take place without other people listening in. That's something that could be addressed and to good effect. Okay, are there any questions at this point? I'm having a little trouble. So just interrupt me, Chris or Holly, if there is a question. Let's talk about SBIRT and in-home health services. Now, some people receive in-home health services who are bound to their homes and may have difficulty getting around. Other people may have in-home health services as a part of a post-operative type of situation. These can be also good opportunities to use SBIRT. And here's a little scenario that maybe illustrates this. We have somebody, we're calling her Alice Watkins. She's a 72-year-old African-American female. She's recovering from surgery after sustaining a left wrist and left hip fracture 2 weeks ago. You are a home health nurse making a post-op visit. Her husband died about 6 months ago, but she has a daughter who lives nearby and helps her in the morning since she works nights. The home aide who visits in the evening has expressed concerns to you about Ms. Watkins' functional status and safety in the home. Now this is really a good situation for SBIRT to be used. And if you have a good rapport as a home health provider, which often you do, you can ask the screening questions in a non-threatening way as part of just an overall look at the person's lifestyle, because we can see right away from this scenario that there are some warning signs here that may push us in the direction of wanting to ask questions about Alice's or Ms. Watkins' use of alcohol. First of all, it's the issue of the wrist and hip fracture. If she had a fall, we know that alcohol plays a role in a large number of falls that people have. She's elderly, living alone, and recently lost her husband, so there are grief issues there. And these two things alone would indicate to us that it might be useful to ask her some screening questions about her alcohol use. This will give us an idea whether or not she needs the brief intervention, and if she does, we can do the brief intervention right there in her home and get her to think about the connection between her falls and her drinking, if there is a connection, and what steps she can take to cut it back. Again, someone in this situation, an elderly person, may not even have come to the grips with the fact that the drinking levels for her, need to be in a healthy range. She may not have had a problem with drinking earlier in her life, but now that she's elderly and now that she has had some falls already, even if they weren't connected with alcohol, she's less steady on her feet. She really needs to consider what her drinking levels are and whether she's drinking at a risky level. So if you're an in-home health provider, SBIRT is useful to you as a tool and should be utilized in in-home health settings. And I think can be utilized rather easily. Okay, someone asked about SBIRT in OBGYN settings. Now obviously, pregnancy itself is an area that requires us, I think, to engage the patient in a conversation about drinking. About 11% of pregnant women drink. 2% have engaged in binge drinking in the previous month. And in fact, prevalence of use of alcohol in the age group 18 to 44 among non-pregnant women is 55%. That's significant, along with the binge drinking in the previous month, 13%, and not using contraception, greater than 50%. This group of statistics tells us that we should be talking to women who are not pregnant, but who may either be intending to get pregnant or leaving themselves open to pregnancy about the risks of drinking if they're in that situation. So put together with the 11% of women who are drinking while they're pregnant and the 2% who are binge drinking also means that we should be using SBIRT routinely in the OBGYN setting. And we can set up a protocol there, not dissimilar from what's used in primary care settings, where people are routinely asked from the first visit about their drinking pattern and other drug use patterns, and given information about the impact this can have on their pregnancy. So if a protocol is set up where this is routinely done, and in general, in OBGYN settings, it should be routinely done even if we're not talking about pregnancy, because I think this brings the subject to the fore early on. It gets women thinking about the relationship of drinking and pregnancy, and because pregnancy is a unique time where motivation can be high, it can be a useful time to introduce the subject of cutting back on your drinking, or in the case of pregnancy, or intending to get pregnant, stop drinking altogether. Abstinence is indicated in those situations. And there is, unfortunately, I think, some information out there that gives women a different message, as though it's okay to have a couple of drinks, or don't drink heavily, or a glass of wine at night is good for you, or whatever they hear on TV. The message that no drinking for women who are pregnant or intending to get pregnant or who are open to pregnancy, that should be the rule of thumb. And we can see that 74% of women stop drinking during pregnancy. So there's no safe levels of alcohol intake during pregnancy, and I think that message has to be given very clearly to women, because there are some other messages out there that are not so helpful. Current U.S. recommendation is abstinence if you're pregnant. Fetal alcohol syndrome. Did somebody say something?
Yeah, sorry. Somebody asked if you have a recommendation for the best screen to be used for these women. Thanks.
I do. I mean, certainly you can use any of the validated screens. Let me just say that up front. But a couple ones that are kind of quick and useful. The first one is called the T-ACE, which is a takeoff on the cage. And you can see there the 4 questions. Does it take you more than it used to for you to get high or drunk? That gets to tolerance. Have you become angry or annoyed when others express concern about your use? You can see that that's similar to cage. Have you tried to cut down or quit? Have you had an eye-opener in the morning to get started after drinking the night before? Any of these questions, you get a point, and 2 points or more indicates high-risk alcohol use, but even 1 point gives you the opportunity to talk to the woman. So this is a quick screen, modification of the cage, which can be used. Another one that's useful is the 4 Ps. Have you ever used drugs or alcohol during this pregnancy? Pretty direct question, yes or no. Have you had a problem with drugs or alcohol in the past? Does your partner have a problem with drugs or alcohol? Do you consider one of your parents to be an addict or an alcoholic? This is a good screening device to begin a conversation about drug and alcohol use. And again, anybody who answers yes to one or more of these questions should be referred for further assessment. So these are 2 screens that can be used, but this does not preclude using other screens like the Audit C or the Audit that Holly talked about earlier, or the DAS-10, or one of those other screens that you may want to use. But these screens can certainly be used as discussion starters if you want to engage a woman in the conversation about her alcohol use during pregnancy. So hopefully that gives some answers to that question. Okay, now I'm going to turn this over, or Chris, can you turn this over to Tracy to talk about SBIRT in the workplace?
Yes. Tracy, just click on that block in the middle of your screen, and we will see yours. There we go.
All right. I was just responding to one of our questions about OBGYN, and I'm going to post a link to the page where there's an archived webinar about the Early Start program. It's a program specifically for that setting. It's been demonstrated with good clinical and economic outcomes at Kaiser. We're certainly hoping to replicate it in other healthcare settings, but I'm going to post that. That's what I was in the middle of doing when you switched over, just so that you can have a link to both the slides and her presentation. I'm going to go ahead and pull that up, and I'm going to talk about the application of SBIRT in the workplace. I hope that everyone can see my screen and my slides.
Yes, we're fine. Thank you.
Okay, great. And if you have questions again along the way, please welcome questions. I know we have a small group of EAP folks, but there may be some other workplace-related settings in which you work. I'd also like you to think, as I identify some departments or settings within the workplace even though I'm talking about them in the context of the workplace, let's say, for example, health promotion. Health promotion happens in other settings. Occupational health and safety happens in other settings. So even if you're not in the workplace, you're not in the EAP, but you're working in a community setting, you might be working in family services community setting where you're doing health promotion. It's the application of SBIRT in health promotion regardless of where it is. There's a kind of a natural places where SBIRT can be implemented within a health promotion and wellness program, for example, or a safety program. So hopefully you can glean things for this in your settings as well when you have programs like the kinds you have in the workplace. So the settings in which we've been doing a lot of work in the workplace, particularly employee assistance programs. I hope people are familiar with employee assistance programs. I'm always surprised how many people don't even know they have their own employee assistance program. I think it's one of the most underutilized places for employees for a variety of behavioral health issues as well as life stressors. EAPs tackle a variety of things that workers call in about, not just emotional issues, which are at the top of the list, but family, financial, legal, elder care. So employee assistance programs really address a lot of things, and what we've been trying to do is try to find a natural place within employee assistance programs who are trying to address such a broad array of what we call presenting problems, what the client or the employee is coming to them about, and how do you integrate it regardless of the presenting problem. So you can imagine in basically all EAPs, what we find is people just don't come in for alcohol use issues. I mean, there is a very small percentage, but it's extremely small. Most people associate employee assistance programs with employee who's gotten in trouble because of alcohol use. It's kind of an old stereotypical kind of view of EAPs, but that's really a very, very small proportion of the kinds of cases they get. So our goal is to really, how do we seamlessly integrate SBIRT into protocols for dealing with a broad array of issues when that's really not the primary presenting problem that people call in about. And then health promotion and wellness programs, I mean, these are programs that might be around stress and parenting and obesity and pre-hypertension, hypertension, diabetes management, nutrition, a variety, again, lots of other topics. How do you integrate seamlessly talking about early intervention and early screening for alcohol use in these contexts? Occupational health and safety. From a workplace perspective, this is extremely important. How do we reduce risk, and how do we integrate into our occupational health clinics or our risk seminars, that kind of thing. Fitness for duty, I mean, particularly if you're looking at some of the organizations we've worked with, if you work with the DOT, Department of Transportation employees, nuclear organizations that are regulated by the Nuclear Regulatory Commission. Fitness for duty is big in hot and safety sensitive, within organizations who have a lot of safety sensitive positions. And how do you do that? How do you integrate screening into that? Sometimes people assume that fitness for duty is really about somebody who's been identified with perhaps a substance use issue, but it's a variety of issues that people might not be fit for duty. So how do you integrate early identification around alcohol use, around cases that may be complex medical conditions, to try, we hope, to not exacerbate the physical health conditions? How do we reduce risk around alcohol use so that people can attend to the other complex conditions that they're trying to resolve or manage in their life to get back to work? And then disability and risk management, that could be psychiatric disability. We've worked with disability and risk management programs, for example, when a company might have 12 women who were all pregnant at the same time, and they're going, using their benefits. We try to integrate routine screening around the services that they're offering around not just alcohol, but around depression, to make it a broader application of SBIRT around a core set of behavioral health conditions. And then in disease management, this could be alcohol disease management. How do you integrate motivational interviewing strategies that you use in the context of brief intervention to have conversations for people who are at very high risk in a disease management program? But it could be other disease management programs like diabetes disease management, depression management. How do you integrate it so that you're focusing on a broader, helping the professional to broaden their understanding of how do I address alcohol use that could be exacerbating this other condition that I'm working with this employee about. So those are the kinds of areas that we've been working in. And I'm going to show you a couple of initiatives that we've been working on to really help workplace settings adapt what's been developed over in the medical arena for a non-medical setting. I mean, what we know and see and learn and the resources available to us over on the medical side, when we bring those materials over to the workplace in these departments, folks will tell us, you know, that doesn't look like me, that doesn't sound like me, I can't use that. You're talking about, you know, physical health conditions that we don't deal with, let's say in employee assistance programs. I see cotton balls in your training materials. We don't have cotton balls here in a behavioral health setting. So we have to really work to adapt it, and that's what we've spent, I don't know, the last 6-7 years doing, is developing those materials, developing the training materials, developing the protocols that are adapted for the workplace, and to also help organizations over in, let's say, not just employers, but large managed behavioral health care companies. How do you adapt your systems and infrastructure to integrate routine screening with across your book of business? And what does that model look like? And of course it will vary, but I'm going to give you a sense of a couple of the models that we've piloted with managed behavioral health care companies and with some smaller EAPs. So what we know is that that there's a huge impact on the workplace. I always find it kind of funny when I'm talking to folks up in the C-suite who say, alcohol, that's not a problem for us. You know, we know what our problems are. Our problems are hypertension, diabetes, and asthma. You know, they're very clear that their bar chart says these are the top things that are affecting my employee population. Those are things they want to attend to. But you don't get diagnostic lab results, a lot of lab results around alcohol use. You don't have screening and brief intervention codes that are somehow get reported back to the C-suite. You don't have diagnostic codes for risky alcohol use. There aren't ways of capturing the data to inform leadership within these organizations that alcohol use is an issue, is a problem. It could be that it's impacting employees and their families because they are serving the covered lives, which are dependents of their employees, and helping them to make the connection between that risky alcohol use is related to accidents and damage and injuries and excess health care use and ER visits and excess hospital stays, making the connection for them about productivity. I mean, we used to count widgets and keystrokes. Well, we don't really have a good way always of measuring productivity in that traditional sense, and helping the employers use tools like a presenteeism scale or other ways to assess productivity. So we try to help them not only implement a screening and brief intervention program, but also how do you implement measures around productivity and some of these other things to see whether integrating an SBIRT program is actually having a positive impact to reduce some of these things that are very painful cost points, regardless of whether it's showing up on their bar chart. Okay, let's see if I can get the slide to advance here. Well, we may have a slight delay. Let's see. Okay, there we go. So, you know, often when we're working with workplace settings, there isn't always a connection made that heavy drinking really increases the risk of these kinds of health problems: depression, sleep problems, hypertension, and cancer. It's often new information in these settings, whether it's for the practitioner or for stakeholders and leadership within an employer or other kind of organization. They don't make the connection. And so part of our work has been to really help bring the clinical and business case to employers and other organizations about the risk. And then to help them make the connection around the safety risk. There's short-term safety risk. I mean, if you're working in DOT or a nuclear regulated setting, these are both of these are big issues: impaired judgment, reaction time, and distraction. And so these are the kinds of things that I do think help stakeholders and leadership pay attention when they realize, oh yes, depression, emotional issues, and that's an issue that a lot of employers can actually wrap their mind around now. It wasn't like that 15 years ago. But when we help to make the connection and alcohol is connected with these things that they know that their employees are experiencing, it sort of, you know, makes it more real and hits home for them, that maybe they need to pay attention to it. Some of these things are very surprising when we work in workplace settings, that the prevalence of alcohol use, risky alcohol use, is higher in certain industries. I've done a lot of work in construction and hospitality, and you know, they see many of the kind of the social norms around drinking as being, so that's what everybody does. But when you work, if you're working with an employer, you're working with organizations or employees that are working in these industries, you do tend to see a higher prevalence of risky alcohol use. And so we try to help employers who are saying, well, I don't want to start with providing screening to everyone. Where could I start? And we say, why don't you reach out to an employer or a group that is in one of the higher risk industries. You can make a difference there. Some other things that seem to be surprising in workplace settings, some of the folks that we work with, is that the majority of problem drinkers or risky drinkers are employed. Sometimes we hear stereotypes that these are people who are unemployed, and they're people who, got in a lot of trouble and ended up in prison, or they're homeless, or they're this or they're that, and they're really not. They're really people like us every day that we're working with, and that kind of makes it real for employers that, well, maybe there is something that we need to be paying attention to, and it's something they've ignored. When you help bring home that alcohol-related absenteeism and tardiness and poor work quality is caused by at-risk drinkers, not the stereotypical employee that they see as the person who is addicted to alcohol, who's automatically going to show up in the EAP. We know this person has a problem. A lot of times folks will associate these kinds of impacts with that very small percent of the portion of the population, when in fact it is a much larger group of people who are driving some of these outcomes in the workplace. And then I bet it's, we ask employers, well, if you surveyed your employees, what proportion of the folks do you think would say that they've actually covered for a coworker, been required to work harder, or injured due to coworkers drinking? And they'll say, oh, that's just, those aren't problems that we have. That wouldn't happen here. Well, when you tell them that the estimate is about 20%, and then you calculate that for a company who has 150,000 employees, or how many ever employees, it wakes them up that, it seems like a really shocking number that this kind of thing happens. So we've been working under an initiative called the BIG Initiative, the Brief Intervention Group Initiative, which really started out focusing on workplace and trying to help make the business and clinical case. So not only we think this is information you can use to help build your case of why you might want to work with an organization or work within your own organization to do screening and brief intervention. We've also created, to help you with that, a tool called the Alcohol Cost Calculator. So it's alcoholcostcalculator.org, and perhaps Jim or Holly, one of you could type it into the chat feature, alcoholcostcalculator.org, and it really can help you make the case for why alcohol use might be something that an organization wants to tend to. It helps you by using very basic information, the size of the company, the industry of the company, and the region of the company, and using a national household survey and a lot of fancy modeling behind the scenes. You enter in that information, and it will estimate for an organization with those characteristics excess healthcare utilization, hospital stays, and so forth, dollars associated with those visits, and so on. So I would encourage you to use that tool. It's publicly available, and we found business groups and even managed behavioral healthcare organizations who are using it to help make the case of why early identification is important. We have lots of tools available from the big initiative. And I would just want to make sure that I acknowledge, you see a lot of logos there. Well, that's because all of these organizations have played such a huge part and make available a lot of the resources that we have, and vice versa. And the big initiative is is a partner and an umbrella within the national SBIRT ATTC. So it is something that functions with all of the website. So we exchange a lot of resources. I think you can link now back and forth to our resources. So we're well integrated at this point. And I would say that you see these associations. Some of these you may be members of. NADAC, obviously a lot of people recognize, but these are associations who come together from EAP, the addiction professional industry, sites from the SAMHSA grantees, SBIRT Colorado, nursing societies on addiction, ASAM, of course, a lot of people recognize, addiction psychiatry, social work, and EAP, and so forth, have come together to create what we have as a learning collaborative. A learning collaborative where we come together quarterly on calls to share about what's going on around workplace SBIRT. And then we also have the big hospital initiative, which I mentioned earlier, where we come together around hospital-related SBIRT issues. So if you are interested in either of those, or separate groups run separately so that you're joining calls and getting resources that are specific to your interests, we certainly welcome you to do that. And so this big initiative project that I'm talking about, I just want to also acknowledge that we've had a lot of seed funding through the National Highway Traffic Safety Administration and SAMHSA and CSAT and the Network of Employers for Traffic Safety. And over time, we've gotten unrestricted grants from Alkermes and other organizations. And now we're really primarily supported through corporate sponsorships, where industry has stepped forward and said, SBIRT is a really important issue. The field has embraced this, and this has been a shift to say this is something that's really valuable. And you can see there's some organizations here like Aetna, Optum, which was United Behavioral Health, Value Options. They became our research partners to do pilot tests. And we built an international network of trainers, and the trainers are on the National SBIRT ATTC website. So if you're trying to find a trainer, there's a map. You can find trainers. And then now our Big Initiative members. So our Big Initiative members, this is just a very small sample of those organizations, and you can see they're representing all different types of industries, and their employers and clinicians and associations, and we've had participation from representatives from the federal agencies. We probably have 100 members, and they interact with the brief intervention group the way that makes the most sense to them. But our whole goal of working with them is to help these organizations find ways to implement SBIRT in their workplace settings wherever it makes the most sense. So we welcome the opportunity to work with you as well. And through working with these organizations, we have been able to adapt. I say that a lot, but it's so important. You know, how do you take a model that's in a hospital, in an ED, in a trauma center, in primary care, in an FQHC, and how does that even make sense in a workplace? Particularly if you're going to bring in the EAP as a focus of your SBIRT program, and health promotion and wellness and occupational health. And over several years of working with the brief intervention group and our thought leaders in this field, we essentially kind of drilled down to this kind of model that along the left is what we realize in workplace settings is most people across many of those different departments, particularly EAP and wellness and health promotion, most people come into that by a self-referral process. I mean, that's mostly how employees would end up interacting with or encountering screening and brief intervention is through a self-referral process. But it also has been tried and has been with mandatory referrals and recommended referrals by supervisors from an HR suggested kind of route. What we also have found is that in these workplace settings, there's a lot of automation around 24-hour automated screening, web-based or telephonically. There could be a triage kind of telephonic service that's available. It could be an after-hours service where people are calling in. We also recognize that health risk assessments or health risk appraisals, often known as HRAs, are really big among a lot of large organizations, and that's a really, really great way to identify people and get them referred into either an occupational health and wellness setting or an EAP. Because what we found is a lot of, when you're working with HRAs, is that a lot of folks may get a little bit of written feedback on a report, but a lot of organizations don't really do much with the conclusion or whatever was found from that risk assessment. They might say, you know, we suggest you go to the EAP, but we found that that's not even often the case. There might be a little bit of education. It's a perfect opportunity to beef up the feedback that you're giving to your employees, and then to help make a linkage to the EAP or the wellness clinic. Same thing with annual physicals. If you're working in an organization that does a lot of annual physicals, that's a great place to integrate screening and brief intervention, and integrating into your HRAs and your health screens valid tools like the Audit C, for example, and replacing unvalidated questions with validated questions. And then as you see the arrows going to the center, this is suggesting that you have all these entryways and options for doing some maybe pre-screening, but also to really move them into the EAP or occupational health area where they would do a full screen, and that's also where they would do the brief intervention. So it could be that it's a telephonic EAP, could be a face-to-face EAP, but there's where the SBIRT would be happening. Same thing in the occupational health and wellness clinics. You could have an occ health nurse, you could have a health educator, you have social workers that are sometimes embedded into these programs, you have physicians, you have fitness staff. There are lots of opportunities for training folks in these settings to do screening and brief intervention and referral. Now, referral is a huge piece of this. In the context of EAP, referral is a really key piece, and that's a piece that we really stress in this model, is it's not just good enough to hand them a piece of paper, but with a couple of names and phone numbers on it, but we really stress, as a behavioral health professional, you have the ability, the artfulness to do a linkage and a warm handoff that's meaningful. And so why not use that opportunity to deliver people to the next level of care? So it's something we really stress in this model, and I think it's feasible in a workplace behavioral health setting. not always feasible in every other medical settings that I've worked in where they said, we just can't do that. But you have that luxury, I think, in this setting, and I think you can do that with occupational health and wellness as well. They have the luxury of doing that kind of warmth transfer. And then on the right side is really to let you know what are the things we're interested in these kinds of contacts. We want to see whether screening and brief intervention makes a difference on absenteeism, on productivity, presenteeism, being present at work. Do their performance evaluations over time improve when there have been signs and symptoms recognitions that have suggested that there might be work performance problems related to things like coming into work hungover and missing work due to an alcohol-related event? And are there other things like decreased risk, decreased consumption? Are we increasing identification rate of our employee population over time? Is it making any difference? So this is several years of work sort of summarized up into some visual that I hope that you can think about how that might work in your setting, or glean from it something that might be able to help. And let's see here. Let me see if I can.
Tracy, did you see the question that's there? Do you want me to read it to you?
Let's see here. A question I do not see the question. Could you read it to me?
Yes. It says, I have encountered a lot of resistance to SBIRT or even training and education for SUDs in the workplace. What do you think is causing the resistance, and how to make the case to the employers? This person is a CDC educator and an LCDC.
Yeah, every workplace is different. I usually have to try to get into the mind of that workplace to understand, is it fear that we're going to discover something that they would prefer to ignore? Is it because there's a liability issue? And if they discover something that has a legal implication, what is it? Sometimes it's really from a place of that. Sometimes I see that I get the reaction, well, we just don't have time to address this. This is not what workplaces do. This is what my healthcare provider is supposed to be doing, or this is what my vendor is supposed to be doing. This isn't something I should have to do. There are so many different scenarios. I would be glad to have a conversation with you afterward about what you've experienced, and then to help you give some specific tailored strategies to your situation based on my experience. One of the things that we do find is when we use the kinds of information I shared with you around the prevalence, around the impact on business outcomes, particularly the economic argument. When you start making the economic argument, people are more likely to attend to what you're saying. If I say it's the right thing to do, they say, oh, yeah, of course it is, but somebody else needs to be doing it. When I tell them it could be impacting their bottom line, and I run the alcohol cost calculator numbers specifically for their organization, I usually get a little bit of a, well, let me go run those numbers. And sometimes they do. They'll go back and run their own numbers. I've even had folks come back and say, actually, our numbers were higher. So, feel free. You're gonna have my email afterward. Feel free to email me, and we can set something up. I'd be glad to talk to you more about that. It's a challenge I like to take. I like to take on. Are there other questions, Chris?
No, that's it for now. Thank you.
Okay, great. Let's see if I can get this slide to advance. Having a little bit of a delay. Let's try this. There we go. So, some of the resources that I mentioned around that have come out of this initiative with our partners is standardized training curriculums. Through this work, I mentioned you need to adapt. Well, then you need to come up with some guidance to help folks really guide their implementation, guide their training. There are lots of resources that we needed to develop, and so we've spent the last 6 years developing a lot of this work. So there is available an EAP and Behavioral Health Professionals Guide to Screening and Brief Intervention and Treatment. It has a lot of the rationale behind it. It also goes into the tools that you use and how to implement them, how to score them. It offers protocols, and it breaks down the brief intervention. It gives you sample dialogue and how to have a brief intervention, and it works through the referral to treatment, some of the really important aspects to keep in mind when you're considering referral to treatment, and how to do the warm handoff and the linkage. So that's available to you, as well as we have worked with NADAC to adapt the guide to be specific for addiction professionals, using the context and the language and the kinds of scenarios that addiction professionals would encounter. And what we think will happen, and I don't know, but I think under healthcare reform, the opportunities for addiction professionals to provide early intervention services like SBIRT in medical settings is coming. And what we hope that this tool will do is help addiction professionals see how can they be on that end of the continuum on the earlier intervention end, and how do they implement it from their perspective in a broad range of settings. So these are available, and you have the websites for those there. And so what we found through this work and through our pilot studies with large external managed behavioral health and EAP organizations, and also with medium-sized and small internal EAPs that are embedded with an organization, we see that this is very promising. And there's a growing body of work around this area. The Colorado SBIRT folks are working with Colorado State Employee Assistance Program, and they've done some work with peer assistance services. They're a great example of kind of what's going on. Karen Chanosilla out at RAND, she was at the University of Washington. She's been doing some work. And there aren't that many others working in this space. I think Rich Brown has done a little bit of work in the workplace arena as well. But I think there's a real opportunity and a growing interest, both at NIH and, of course, SAMHSA definitely supports workplace initiatives. So what's really exciting, I think, for us at the big initiative is working with the EAP leading associations like EPA, which is the professional association for really looking at the individual practitioner level. They really represent that group very well. And ISNA, which is the trade association for the employee assistance field. And working with them over these years, EPA has recently endorsed SBIRT as a standard of practice, and ISNA has endorsed it as a best practice. And that is a huge milestone in moving a field forward to really bring some attention to the workplace and the opportunity to do early screening and brief intervention. And then what we've seen is a lot of business groups support routine use and making statements of recommendation and endorsement, and business coalitions likewise doing the same around the implementation of SBI in workplace. And then we have some studies which are really very new in the field that have shown this to be a promising practice. And if you're interested in a review article of workplace, some of the workplace literature, I've provided a link to the one that is currently available from SBIRT Colorado. So let me just show you a couple of results of the studies that are new and have come out. And just to give you kind of a mental picture, you're going into a field that historically has focused on the highest risk population. These are the people who automatically show up in employee assistance professional's office, or already, they've been mandatorily referred. What we're shifting the field to do is go back to their core technology and their core framework to shift the case finding. That's a huge shift for many people in the field today, and bringing them back to look at the full range of risk and how can we intervene at all different levels, and how can we be responsive to employees no matter where they are along the continuum. So in doing case finding, they weren't necessarily, EAPs weren't used to asking about alcohol on a regular basis in a systematic, validated way. So what we did is worked with their call centers and with some of their internal, say, face-to-face, and we worked with them to do use the audit C if they were doing an initial kind of triage call, and then working with them to hand off to a EAP practitioner who would then take the call and do the full audit and provide the brief intervention. That was one model. Or you have some employers which they have what they call a clinical first model. So they call their EAP, their Managed Behavioral Healthcare Organization, and they get a clinician automatically on the phone. They pay for that service. You pay for the kinds of levels of services that you're expecting to get. So we needed models that would adapt to those different levels of models, but also different levels of the types of professionals that fill those positions. So we also had models where they did, and they embedded the audit into their clinical intake by the clinician, who also screened for substance use. They may use the DAS or one of the NIDA single items, depression using the PHQ. So we embedded it into their clinical intake, and they ask about lots of other questions too, as many of you know from doing clinical intakes. And then we help them to learn how to integrate conversations about alcohol use into the context where an employee is called about everything else under the sun except for alcohol use, which is a shift. You're used to responding only to the presenting problem, and now you're shifting to have a more kind of a holistic, whole person perspective that we're trying to look at the relationships between alcohol use and, say, emotional concerns that they're calling in about. Not that they're looking for them as if to try to find them, but just to have the tools so if there is something else going on, they've got the tools and the screening instruments and the intervention, the training around the intervention to help make the connection to, let's say, someone who's having a marital problem or a financial problem, or whatever the presenting problem is. So it takes a lot of planning, like Jim said. You need to really think about how it's going to be implemented before you do training. And then you really, one of the lessons learned for us was you've got to get the buy-in of the staff first before you start doing any of this, and work through what the resistances are. You know, there's some very seasoned professionals out there, and what we're not trying to do is say what you've been doing for 20 years is wrong, or what you're doing is ineffective. What we're trying to do is really enhance their toolbox. They could be doing a lot of effective things, right? So let's enhance their toolbox with evidence-based practices and help them to get comfortable with it. And so you have to kind of get past the fears of them being judged as not perhaps being as judged as, well, I've been there for 20 years and I know how to do this. And they get fearful. They don't want to engage in the motivational interviewing training, or they don't want to engage in the practice sessions because they're fearful of, you know, someone's, their supervisor's opinion of them. So you have to work through a lot of that stuff that's going on, that dynamic, before you do training. And then plan out how you're going to capture the screening data, the brief intervention data, and the outcomes. What are you going to measure? Are you going to do follow-up? And that's what we did in our model. We integrated an administrative follow-up, which might be 7 to 14 days after the initial screening at the clinical intake. And then we implemented a 30 and 60-day, what we call clinical follow-up, which means there's something more than just asking about, did you make it to your appointment? We might engage them in another risk assessment using the audit C, that sort of thing. And what we really found across the sites, we had more than 3 sites, but just to highlight for you, is that when you implemented routine screening using a validated tool, before implementing it, the identification rates range from less than 1%, which was their organization's identification rate that they, when they're looking at presenting problem in their utilization reports. We had some sites that their baselines were around 7%, That was actually quite high compared to most of them. Most of them are less than 3% baseline. So if you're working with organizations, pull the utilization reports and see what kinds of presenting problems and identification rates that you have. And then once we implemented routine screening and brief intervention, the identification rates dramatically increased using a validated tool. And we had rates that really approached the population, the prevalence in the population, somewhere between 18 to say 27. But there were some where we had rates as high as 40 because it's a help-seeking population. So in some sites, it wasn't uncommon to see 30, 35, 40% identification rate. So real significant increases in identification, as you can see here. And then what we found in follow-up was that there about a quarter in some of the internal EAP sites, about a quarter of those who had scored at risk had decreased their consumption, both daily and weekly. And in other cases, the way we looked at it is what were the reductions in audit scores themselves. And we found that folks in the moderate and the high risk over time did, on average, their average score of that group did reduce, moving from one category of risk to the other. So we see it as very promising, but a lot more work needs to be done in this area, and we hope to be able to do some of that work. So thank you so much for listening to me talk about this. I'm obviously extremely passionate about this area, and if anybody would like to have follow-up conversations, here is my email. That's just one of them, but I think there might be a different one that was listed in the beginning. Either one of them work. So, Chris, are there any other questions while I pull up some of the contact information, the links that are available to you for the websites that I mentioned, the Big Initiative Workplace listserv, and, of course, you know about the National SBIRT ATTC site, and then you can join us on LinkedIn as well.
Thank you so much, Tracy. I don't see any other questions coming in, so I'm going to put this back to Jim to wrap things up.
Great. Thanks, Chris.
Okay, Jim, just click on the box. There we go. We have you back now. Thank you.
Okay. All right. Well, we're getting very close to the end here. I'm going to go very briefly through the use of SBIRT in some other settings, and then we'll be done for the day. And thank you for your hanging in there. Let me get rid of this so I can go ahead and there we go. Okay, so let's talk a little bit about SBIRT in STD clinics. I'll give you hopefully a useful link that you can look at of a program in New York City, that Project Linked, which is an effective program and bringing the SBIRT model into STD clinics there. We know that alcohol and drugs and sex don't mix, obviously, and that in a kind of targeted study at an STD clinic in Indianapolis, the study showed that over 46% of patients screened positive for at-risk or probable diagnosis of substance use disorder, and of these, more than 50% were in the pre-contemplative stage of change, if you remember back when we were talking about the stages of change. And so it is very important that we may be surprised a little bit. We may think that people who have STDs or are reporting to the clinic might begin to think that their drinking or drug use plays a role, but in fact that's not the case. And so it's a good opportunity for us to introduce alcohol screening and drug screening into the STD clinic so that we can give good education to patients who are coming to the clinic and also link them to treatment for substance use disorders if they need that kind of treatment. And that's the purpose of Project Link in New York City, to connect STD clinic patients who are engaging in risky or severe substance use behaviors to substance abuse treatment services. As we know, this population engages in all kinds of risky behavior, and so their substance abuse behavior is risky as well. And there's a website down there, if you can see it's in smaller print. It's the OASAS website, the Office of Alcohol and Substance Abuse Services in New York State. And if you go to their main website, you can certainly type into the search box project link, and you'll get some information there about how they use SBIRT in the STD clinic in New York City. Another interesting group that we might want to talk about SBIRT to are faith-based organizations. These are really good, I think, and possibly even fertile grounds for the use of SBIRT. Faith-based organizations are embedded into communities. They often have the trust of the community. They can deal with the diverse cultural and religious groups. These are churches, synagogues, mosques, places like that, but also associations that some of these religious organizations belong to. A number of years ago here in our area, we developed a relationship with a group called the Caring Congregations Network. This was a network of faith-based organizations, and did some education with them around SBIRT and using it in their congregations, and got actually a pretty warm reception from that particular group. There's a couple of bullets here I think that are useful in looking at. I hope all of them are, but SBIRT training for faith leaders is an opportunity to disseminate accurate information about substance use disorders. We know that sometimes in the faith-based world, substance use can be looked at as a moral issue. This gives us an opportunity to give some education to faith-based leaders about the medical or disease aspects of addiction itself, but also, again, paying attention to the whole continuum of substance use disorders. And it also gives the leaders a structured tool to help their congregants deal with the serious issue. So these folks are going to see people who have the full continuum of substance use disorders, not just people who are addicted or who are dependent on alcohol, but people who are abusive drinkers, risky drinkers, all kinds of folks. And they can often benefit from a real and detailed way of dealing with congregants who have these problems. And so they're often eager to hear about SBIRT because it's an organized model that they can learn and use in their dealings with people who are members of their congregations or who are coming to some of the health clinics that faith-based organizations sometimes sponsor. So don't forget about using SBIRT with faith-based communities. It can be a very powerful tool in that setting. Just briefly, SBIRT and the homeless. We know that this population, besides dealing with mental health issues, often substance abuse issues are a real complicating factor. But these are not the kind of people that are going to walk into a substance abuse clinic and ask for help. So it's really to outreach organizations, people that do outreach to homeless persons, that again, SBIRT provides a good tool, a good mechanism that can be used to engage homeless people in a discussion about their alcohol use and how it may be affecting their life situation and their health. So particularly groups that do outreach to homeless can benefit from using SBIRT as an outreach tool. And finally, SBIRT at health fairs. Some of you may be involved or asked to participate in health fairs. And SBIRT can certainly play a role there. Screening for unhealthy alcohol use particularly can be useful at health fairs. It may work best if it's part of a healthy lifestyles kind of an initiative. If you put up a sign that says, come and we'll tell you if you're having a drinking problem, people may not visit your booth. But if you talk about healthy lifestyles, which includes healthy eating suggestions or other kinds of screens you may do, and include screening for alcohol and tobacco use at these health fairs, you may get some business, and people will listen to you and participate in the screen and receive education, information, and feedback that you may be able to give them in that setting. Obviously, there needs to be a realistic plan to make referrals if people have serious problems that are uncovered in the process. Some information about drug and alcohol clinics in the area that can be useful or given to people in that context as well. There's a particularly good brochure that's published by the NIAAA called Rethinking Drinking, Alcohol and Your Health. Again, you can get a lot of these sent to you for free, Rethinking Drinking from the NIAAA, that you could use at health fairs to give to people, to hand out to people, which gives them good information about what healthy drinking looks like and what risky drinking looks like, which we can never underestimate the fact that people don't really think about this very much. And just giving them that education or a brochure like that can be very, very useful to them. Sometimes people will hear on the 5 o'clock news, that it's very good for your health to have a glass of red wine, every day. But nobody ever talks to them about what unhealthy drinking looks like. So a health fair can be a good opportunity to introduce the notion that there can be levels of drinking which are not beneficial for your health and, in fact, are dangerous for your health. So health fairs are a setting where SBIRT, and especially the screening part of SBIRT, and even the brief intervention can play a role for sure. So we hope you can agree that the SBIRT is an integral part of general services which can occur across the board, not just limited to healthcare, but certainly healthcare is an important venue for SBIRT. We've talked about the workplace, educational and behavioral health settings, and other kinds of settings where SBIRT can be useful. So the other thing I think that it's very important that this model brings to the community is accurate information about what unsafe drinking levels are, and also it goes a ways to normalizing the fact that people are going to be asked about their drinking through validated screens, and possibly over time will help reduce the stigma that's associated with alcohol and drug use in our society. As Holly mentioned, America is a place that loves alcohol and drug use, but sometimes stigmatizes people who develop conditions related to their unhealthy use of alcohol and drugs. If there are any questions now to wrap up, we'll be glad to entertain those. Chris, do we have anything on the board at this point?
No, there's nothing here. So if people have any questions, please send them in now. We have a couple minutes left before the end and would like to answer any concerns you have.
And if any questions come in after we're done, we'll address those as well. But here's some contact information for us. Please feel free to contact us. As Tracy mentioned, we'll be glad to talk to you further about SBIRT as it applies to your specific setting. And thank you so much for participating in today's webinar.
Yes, thank you, Jim. At this time, I'm going to stop the recording, and I will give some last-minute instructions.